So that's why you got to be careful when you are recovering from a fracture. The medications, remember that there are some medications, especially chemotherapy agents, they're taking cortisol or cortisone. That prevents bone formation. So then the other thing, location, duration, and frequency of pain. I can't emphasize this enough that many people just put the patient on the table, they scan them, and then they let them go, and then they realize, oh, the guy had a tumor in his arm or in his leg or something. I like using my daughter as an example, but she had a patient come in for a PET scan. Normally with PET scans, you just scan from like the base of the skull down to the thigh for most cancers. If it's a melanoma, you scan from the top of the head down to the thigh. Okay. Turns out this patient had a osteosarcoma in his ankle. They cut off his leg, his foot. Guy didn't bother to tell anybody that that's, they were looking for renal cancer, but the guy also had an osteosarcoma. So the thing is, you need to ask questions. Okay, so location, duration, and frequency, make sure that that's included. And if it's an arm or a leg, you may have to do lateral views like you're aware of. Serum alkaline phosphatase, this is your clue that bone is being damaged. Okay, when these levels are up, something is attacking the bone. Prostate PSA levels, I don't know if that's really going to make any difference or not. Usually prostate cancer invades locally, and then if it gets to the bone, the PSA is not real reliable anymore, they're finding so. Then the last thing here, if they've had any recent, if they've had chemotherapy or radiation therapy within the last 6 months, then you develop what they call a flare phenomenon. And this is where the bone marrow becomes reactive and takes in more of the, it becomes hyperemic, okay? So it'll take in the bone scanning agent, and it looks like it's hot, and it will look like it's in the bone, but it really isn't. Does that make sense? So this is what they call a flare phenomenon. Also, there's some pictures of it, there's some in our book. But the thing is that anytime you irradiate a bone or you get chemotherapy, you stimulate the bone marrow. Okay, so it gets hot. Here's some examples of, these are in the book. Okay. What's interesting about X-ray, it just shows that there is a fracture to the tuberosity of the fifth metatarsal. It's a very common fracture. Usually this is because of an inversion injury where the feet turn in. But if you notice over here, this guy has a lot more injuries than just the tuberosity. He has quite a few of the tarsal bones that have also been injured. Yeah. And then over here, this is a stress fracture. Again, in most cases, unless the patient really brings it to your attention, I've had stress fractures that where you don't even see them. But here you can see where it's formed a callus. It's healing. It may have been originally that thing didn't even show up on an X-ray. That's very common. The resolution of our cassettes isn't high enough. I mean, unless I do a high-resolution cassette, which most hospitals don't have, they typically have the 1024 by 1024 cassettes. When we got our digital system, I also ordered a 2048 by 2048. So that's 4 times the resolution. And mammography is 3096 by 3096, just to give you a clue. And that's on a very small cassette, so it has very high resolution. But anyway, so here's what a stress fracture looks like. Notice it's hot on the flow, hot on the immediate, and hot on the delay. Okay, that's also what osteomyelitis would look like too, isn't it? So you got to make very sure you know what your diagnosis is. Otherwise it may be whacking this guy's foot off. Okay, so that's a stress fracture that's healing. Okay, then this is the flare phenomenon. So remember, all of this stuff that looks really horrible here, this is not metastasis. This is just hyperemic bone marrow that's reacting to the radiation or the chemotherapy. Okay, now They redid the scan after this. This is actually right out of your textbook, and this is what the patient actually has here. This is the metastasis, and it doesn't look as bad as over here. I mean, I wouldn't want it, but you know.
It looks terrible though.
Yeah, it's a lot. That's not good. This is breast cancer, and you know the thing about the two cancers that we hear the most about are breast and prostate. And breast has this tendency to spread through the lymphatic system to the axillary nodes, but it also gets into the bloodstream. And normally, if cancer gets into blood, it winds up in the bone. If it gets in the lymphatic system, then it's going to be in the lymph nodes. So, with prostate cancer, it normally just winds up in the blood, and then it's in the bone. So, like I said, make sure you find out when that patient had their treatment. You know, most of our people are patients that have had some kind of chemo or radiation therapy, so make sure you're not scanning it too soon after the treatment. You may have to wait a few months. They say 6 months. So this patient...
My question is, why did they do that first scan then?
You know,
Laura?
there's a lot of miscommunication. You guys have probably seen it in the hospital. Okay? They say, Dr. Smith, who knows nothing about oncology or nuclear medicine, has a patient that's being treated for cancer. He says, well, you know, it's probably time for you to have a bone scan. So it's been 6 months, and let's see, well, you had therapy a few months ago, so yeah, it's time. Let's see if the therapy did anything. So they don't know when they're supposed to schedule these people. And that's what normally the big problem is.
But isn't it our job to tell them it's too soon?
Well, how many technologists have you seen don't even bother to ask? Okay, this is what I'm telling you guys. It's all in your report. What happens? That patient should not have been scanned. You're right. But he was. And this is where you come in. What you're learning now is, okay, you need to stop and ask questions. There's a lot of doctors who are radiologists that don't know nuclear medicine. They're great radiologists, but radiologists and nuclear medicine doctors don't do the same thing. And most doctors out there, general practitioners, don't know either. So, yeah, you're right. You are the filter that needs to tell the radiologist that, hey, you know, this guy just got off, you know, chemotherapy 2 weeks ago. We need to wait a few months. Because if you don't, then this is what you get. And so you really don't know if you're dealing with, you know, the flare phenomenon or if you're dealing with horrible metastatic disease. But yeah, that was a good point, Ashley. Okay. I don't know if you have the opportunity to talk to your patients. Do they let you talk to them? Okay, yeah. Okay, so you need to just let them know, okay, we're going to give you an injection. We want you to drink at least 2 glasses of water between now and the time you come back. We want you to urinate as much as you can. Preferably, though, just before you come, hold off and urinate just before we get ready to start your scan. Okay? Now, the typical dose is actually between 15 and 30 millicuries. 15 if you're practicing a LARA, 25 to 30 if you routinely do SPECT. Okay? So if you're anticipating doing a SPECT scan on a patient, then you inject 30 millicuries. Okay?
But you wouldn't know if you're going to SPECT or not until you finish scanning, right? So how are you going to...
Well, at Cedars-Sinai, they just routinely, they do SPECT on everybody. They at least get the lumbar spine. The lumbar spine is one of the worst areas to get a good picture of, so SPECT works real good for that. Knees, facial bones once in a while, but, you know. But like I said, the thing here, I mean, unless they have a reason for not being allowed to drink anything, have them drink as much water as they can.
Patient with kidney problem by dialysis, so they can't drink so much water.
No, yeah, you got to watch that. So that's why I say if it's not contraindicated. And then the best thing is if you can, this is what I do, and I don't know if you guys do it, when the patient comes back and they void, I do a planar image of the pelvis. You guys do that? So that's the first thing. I bring them in there, put them on the table, you know, do a 500,000 count. anterior, posterior, pelvis, and then I do the bone scan.
To make sure their bladder is clear.
Well, not only, if it is clear, that's the best time to get the picture of it.
Right.
Yeah, before it has a chance to fill up, so, just a thought. Some people might think you're kind of nuts.
Yeah.
Okay, the other thing is that the patient comes back 2 to 3 hours after injection. Again, this is where you guys need to sort of standardize your protocols, because, you know, we're trying to do what they call information density scanning. Notice it says total body should be about 1.5 million counts. So that means you're going to take a 1-minute count over the chest, either anterior or posterior chest. And let's say that you have 100,000 counts. Okay, 100,000 counts in 1 minute means that you're going to have to scan for about how long?
15 minutes to get
About 15 minutes. Okay, so 15 minutes. Now, what's the normal speed that you use when you're scanning a bone scanning patient?
12 to 14 centimeters.
Okay, 12 to 14 centimeters. Okay, so if you have a certain range of counts for that 1 minute look at the chest, then you can use that information to adjust your scan time. So if they have a lot of counts, then you can scan 14 centimeters per minute. If they don't have as many counts, 12. But don't just get into that routine of just immediately, regardless of when the patient comes in. They come in 6 hours later, you don't scan them at the same speed.
Right.
Okay? Some people, I see that and it drives me nuts because it's not a good quality scan.
Would we consider it the body BMI? Like, you know, if patients like big, would we scan them a little bit longer than
Yeah.
get more count?
Yeah, it would be a good idea to, you know,
Yeah, because you'll have more background if you scan too soon on a larger person. You can see all their skin.
yeah, when you have obese people, it's
Renal function.
or renal function. Yeah, that's why I don't get bone scans anymore. Okay. So the whole body imaging, that's one way to do it. The other is the spot film technique. Typically, you're going to do an anterior head, right and left lateral, chest, shoulders, pelvis, lower extremities, upper extremities. You guys do spot films?
Is it per hospital vertical?
Lateral the skulls.
Lateral, yeah.
Yeah, I mean, most of the time, you know, this, I don't know, probably takes about the same length of time, but notice it says 10 to 30 images. Hold on a second. Excuse me just a second.